We'll open the floor to questions. We have a few more minutes. I'll start with the first question, which is for the entire group. One of the things that I struggle with as Chief Medical Officer of the American Cancer Society is how to handle the population's response to the evolution of data and the fact that research changes things over time. For example, we have great data that fecal occult blood testing is a great screening test for colorectal cancer, but the population seems to think that colonoscopy is better. We have doctors who think that it's better, despite the fact the scientific data, the prospective randomized trials to support fecal occult blood testing are actually stronger than the scientific trials to support colorectal colonoscopy screening. So how do we get people to accept that? A number of organizations, including the American Cancer Society and Komen, are struggling with this question of should we be recommending screening for women in their early 40s? One of the arguments I keep hearing that we should continue recommending it is the population won't accept a recommendation that says that screening should start at a later age. For the last decade, we have not advocated breast self-exam or monthly breast self-exam, but advocated breast awareness. Yet breast self-exam continues to be around. People just don't evolve. How do we get people to understand that science is going to change over time, and as a result, the answers in our recommendations are going to change over time?
So I'm not sure that, this is probably the wrong panel. You'd want to talk to communications experts about this, and we in health tend to talk among ourselves about how to communicate with the public rather than to the communications experts. But having said that, I will say, I think I would start with experts in crisis communication. When you look at how phenomenally well communication was handled during the H1N1 influenza epidemic, where CDC leadership was able to convey and the public accepted that based on what we know today, this is what we're recommending, and then tomorrow we know more, and now we're changing our recommendation. So this was about school closure. So I think the public, if it's framed right, and done in a very concerted way, probably can understand it. But I think, obviously we're talking about a much less intense kind of focus when we're talking about changing guidelines over time. But I think there's similar lessons to be learned from that.
The first thing I would agree to is I'm not a communications expert, but we can't rely solely on communications experts to get this across. And the reason is very frequent, we're all trained differently, and often communications experts feel like if they can convince people to do what they want them to do, it's mission accomplished. And so a message is pulled off the shelf, and a communication expert will go into their toolbox. Should I use fear? Should I use, as my primary message, should I use promise of benefit? Should I use a combination of both? Make people feel vulnerable and then give them hope that there is a cure where they can change the hopeless situation. And so they do that without actually knowing what the evidence is. So I think one of the strategies in my research, one of my priorities, the top one was education about some of the problems, the pros and cons, because if the public are not even aware that there are cons, and if the health professions are not aware because they haven't been reported fully, then you can't get at that. But I wouldn't rely solely on communications experts because often they're coming at it from a radically different viewpoint, and that is, let's assume that we know what the answer is. Not all communications experts, by the way, but they often assume that the answer is in hand, and now the goal is to get across the most effective way to communicate it. And so I think this is potential for collaboration between the people who generate the evidence and the people who are communicating it.
Yeah, Otis, I would say that health professionals don't even understand this field. So, it's a stretch to think that we're going to be able to modify the understanding of the lay public when they go and speak to their health professional and they can't even discuss this. So, I agree with Barry that we need to document openly and accurately the benefits and harms. We need to, and we are seeing this shift, at least in the field, of people thinking about understanding more risk-based screening. I mean, this is a problem in all areas of medicine. It's interesting, though, there's certain areas where you don't see this resistance. So one example is tonsillectomies are gone. My father was an ear, nose, and throat doctor. He openly admitted that he sent his 8 children to college and half of us to medical school because he did tonsillectomies. And, it's gone. It doesn't happen in medical practice anymore. So there are a few areas where we are willing to make those changes. But in the general area of prevention, it's been a big problem. Because I don't think we train people in medicine what that means.
I'm sorry, Lily?
So when the decisions came down regarding mammography screening, I was very concerned that there wasn't a very concerted effort made to talk to the advocacy groups that would be the most alarmed about this, like the Young Survival Coalition. And they really got in an uproar because that's the population that got diagnosed. So I knew for sure they weren't going to, turn around and say, "Oh yeah, we'll go away now," because nobody's going to be diagnosed in our age group. When it comes to physicians, one of the top medical malpractice is a delayed diagnosis in breast cancer. So I don't know of any PCP that's going to tell a patient if she says, "I'd like to get a mammogram," he's going to say okay and write the script, even though it may not be the right thing to do from a scientific perspective. For medical malpractice, that's the driver.
Let's take questions from the floor. Nicole?
Thank you, Nicole Stout. I was up before and didn't disclose I'm a physical therapist. So when I hear Dr. Levy's questions and Dr. Alfano's questions about why are we siloed and who should be doing this, naturally my mind goes to the rehabilitation community because not only are we experts in movement and function and dysfunction, we do get paid to do this intervention, this type of intervention with patients. And with the cancer population, it's a bit different. It's not your 3 or 4 times a week rehabilitation construct. We're talking about operating in a prospective surveillance model where we do surveillance with patients over the course of time, once every 3 months to identify functional impairments. Another hat that I wear is as a director with the American Physical Therapy Association. We represent over 200,000 physical therapists nationwide. And we are working to elevate and raise the bar in cancer rehabilitation. We've developed a board specialty certification. We're working towards certifying cancer rehabilitation programs with standards around the country. So I would encourage you, as the National Policy Forum moves forward in asking these questions that you've put forward and seeking the answers, you have a cadre of rehabilitation professionals who would be willing to come to the table and talk about models of care and in addressing the late effects, early detection, prevention even of late effects, and prevention of secondary cancers.
Thank you. I'd like to make just a comment on that. The whole idea of lifestyle interventions after cancer, after the diagnosis of cancer, is huge. And I saw Robin Yabroff here, who has done some of the seminal work that look at cancer costs. And I think we need to keep in mind, we've been talking about costs all morning and on through the afternoon. 2/3 of the costs are borne after primary treatment. And so if we are going to make an impact on disability, on loss of independence after the treatment of cancer, this is where the money really is. So I would really like to go. I'd like to go on record that right from this seat right here.
That's where the value really is.
Yeah, But I think that the point that you make is an important one. It's not just a one consult deal. It is one of those things. The treatment of obesity, the treatment of increasing physical activity is ongoing care. And hearkening to the message that Jeffrey said, we have to make it so that people care, and we have to jump on that opportunity, and we have to make it. One of our earlier speakers said we have to make it sexy, or we have to make it new, and somehow it's an old message that needs to be reframed. So I would like to put out how are we going to do that, and engage the panel before we take Dr. Peterson's question.
Well, I don't know if I can answer how are we going to do that, but I want to speak to Nicole Stout's point as well, that, I think I'm looking out at Julia Rowland and Patty Gans, and we've, penned a JCO article talking about calling for a model of survivorship care that's focused on rehabilitation more generally, and looking at what do we mean by that. We don't just mean physical therapy, no offense. We mean literally taking a look at someone as a whole person, and what is the totality of what's going on with you after cancer. Some of which, for example, deconditioning, maybe you came into cancer with because you're an American, and most Americans are deconditioned. But how can we look at you after cancer and get you well in the true sense of what that means? And that's not, it's not a one-size-fits-all intervention. And so we have to look at that as a model and look at that as a way to create well survivors.
I have a response to that. I just, I agree with Jeff that we really are a little too siloed in how we look at a lot of these issues. But I think in trying to answer what I think was your question, I also think that we want to be careful we don't swing too much in the opposite direction too. There is a lot of passion that comes out of very specific diseases and issues, and in the case of cancer, there's not just passion, there's also a certain amount of fear. And those things do help drive some of the resources that come to be able to work on these kinds of issues. So, I think the solution comes in trying to free up from some of the categorization of funding, but not, sort of not losing the advocacy community and the passion that a lot of people feel for very specific issues.
So I guess as an advocate, I would argue that the role of leadership among advocates is to achieve that desilo-ization, and for people to recognize that by coming together we will be stronger and we will ultimately be healthier. And and I think that's a lot. I think what you observed is felt in many advocacy groups, that if we come together and talk about cross-cutting interventions, we will lose our identity. And I think, I was delighted that you had the National Prevention Strategy there, because that was really meant to get all of us to be thinking in that cross-cutting way of being well. We all want to be well in every aspect of our lives, and this is, one of those ways for achieving it. And I guess the second point that I think is going to be important for everyone involved, whether it's clinicians or individuals or communities, is to recognize that small steps make a really big difference. That it's actually a marginal increase in physical activity that creates the biggest health gains, and that we don't all have to be running a marathon. We don't all have to be looking like professional athletes in order to achieve the health benefits of being active and eating healthy.
I promised Dr. Moy I would get her out soon, so if one of you guys has a question for her, why don't you go right now?
I don't.
Either?
No, I was going to.
Okay, Dr. Moy, you can be excused. Okay. Ladies first.
Oh, well, thank you, Otis. Gwen Darian from the Cancer Support Community. And actually, Otis, you were talking about something I've been thinking about a lot, having been in the advocacy community for a very long time, which is where we met. But we don't always think of the unintended consequences of success. And we don't look at what happens when you change. And I think your point is an incredibly important point. So right now in this panel, we're talking about changing changing the public health messages around what you do in terms of breast cancer risk reduction and screening in terms of mammogram and breast self-exam. And then we're also talking about making sure that people go out there and have screening for colon cancer that we believe is potentially life-saving. And people get very angry when you take these things away from you, as you know, as a prostate cancer doctor, what happened. I mean, you know about the PSA screening. So I think it's a very, very complex, really interesting question. And Jeff, to your point, I actually stepped away from sort of body part advocacy into all cancer advocacy because I agree completely with you. But I would say a suggestion is that we end up we don't all talk to each other, so we don't have the public health people talking to the sociologists, talking to the biomedical early researchers, and so we end up developing these communications and these interventions without thinking on a long term. And so that's not actually at all a question. It's just a comment. But I guess I would ask you all what you think is the answer to trying to at least think about a message further down. And I think H1N1 is an interesting idea, but it was an acute problem. It was not a long-term public health message that we're trying to take hold. And I don't know the answer to it. I just think it's a really, really important conversation to be had, and that should not be dropped, and should not just always be left to the end of the day in these forums.
Let me just say, after a 20-year struggle with prostate cancer screening, I have declared victory and moved on.
Yeah, so that's a very important point, and it helps me formulate a thought that I was trying to get across before. This may be the Holy Grail, but it is one of the dangers of, if we ignore it, it's at our peril, and this is the danger of siloing. Each group is struggling for primacy sometimes if they have a specific mission. And so they perhaps it can be understood that they're trying to tone up their message and their language so that they can gain primacy. But we need to be careful that the strength of the message is in sync with the strength of the evidence. And it may be far stronger, and this is the downside of siloing, so everyone can at least, if the intervention has some clear benefits, but it's not for this particular endpoint, then we can afford to be clear about that and say which endpoints the evidence is strong and which it isn't. If we maintain the silo, then I think there can be a terrible mismatch. And when that occurs, if the messages about prostate cancer screening are every bit as strong as not smoking, and they have been, then I think, or the messages about starting screening under age 40 are every bit as strong as colorectal cancer screening, then inevitably evidence is going to come out that undermines one of those messages. If it does, then the public can be forgiven for saying, hey, wait a second, the evidence wasn't so strong. The message was awfully darn strong. Maybe there are other messages that are out of sync with the evidence. And we have to be very careful that in each endpoint and each intervention, we try to maintain balance between the strength of the message and the strength of the evidence.
I just want to say one other thing, which is I think this is a locus of control problem. So when you come out and you tell women, oh, you shouldn't have your mammogram in your 40s anymore, you've taken away this idea. So this idea out there that breast cancer is really scary. I don't want to get breast cancer. So you take away the thing that you told the community they should do to avoid getting it without replacing it with something else that they can do to avoid getting it. So I think there's this people, it makes most sense to me in the context of survivorship, because I've been in survivorship almost my entire career. But, cancer survivors want to feel like they have the reins of control over their morbidity and mortality, desperately. And so they want whatever tools they can have so that they feel like they've got that control. And so that's, I think, part of maybe where this is coming from. I'm not saying it's right or wrong. I'm just saying I think that's a big part of the motivation. And so what can we do to address that motivational component?
Sir?
Yes, thank you. I realize we're over, and I appreciate, briefly, I'll ask my question. The comments from Drs. Kramer and Alfano were the perfect transition into my brief question. And I ask, and I'll ask Catherine, if I may, just in the interest of time, what is the state of the science relative to customizing the interventions for a given patient, after the acute cancer treatment? Is it such that we're ready for prime time of implementation, and that's where, over the next 5 years, policy should take us with funding? Or I'll put it this way, is there more research needed, just like there's more research needed on customizing approaches for personalized therapeutics?
Let me ask you to clarify which outcome you're interested in.
Well, thinking of a patient with a constellation of illness and side effects, financial toxicity, a family injury, for that given patient, how do you know which customized approach for wellness will be most likely successful?
Yeah, no, this is it's a very pointed question, a very good question. I tried when I first came to the NCI to get something going in terms of a funding opportunity announcement in that. And what came back to me was, this isn't the way we do science. This idea of having an intervention that might have components A, C, and F, or it might have components B, Z, and whatever. It's a very difficult model to test using our available research methods. Although now I think as we're going more toward optimization designs, we could do that, but that's another forum.
Well, no, but I think that's actually a critical point, because just as there was a lot of discussion earlier today about new clinical trial designs for testing different drugs, the same thing is happening in the behavioral science area.
Yeah.
And so one of the persons who has been the most frequently invited speaker to NIH forums in this area is Linda Collins.
Yes.
So if one's interested in knowing what's being written in that area, she has a website, so I'd encourage you to look her up, all right? Because they're doing the same sort of thing where they're basically coming up with 6 elements of a particular approach to intervention, and they then stratify their population across that entire 6 elements, but they draw power from being able to compare in any one element. So they actually are coming up with much smaller sample sizes for doing iterative design. So it's being an area that's being actively discussed and debated in the health behavior intervention world.
And Jim Dorshow actually commented on that earlier in his cancer therapeutic trials world. So I think, it's just a paradigm we need to move into survivorship.
And now if we can yield the floor to our leader, Dr. John Mendelson, for the last